Good evening. My name is Kathy Harley, and I'm the CEO of NSWOCC. And I would like to welcome you to this continuing education webinar, which is called Dressing with a Purpose, the Transformative Power of Collagen ORC Dressing with Silver. In addition to learning more about the mechanism of action and infection control properties of this dressing technology, you're going to learn about the proper application techniques, and you'll be able to see the patient experience and outcomes when this wound technology is used. I would like to thank Solventum, formerly known as 3M, and we have Jacqueline and Mariah here with us this evening for supporting this continuing education event. Thank you very much. And I would like to ask everyone, if you do have a question during the presentation, if you could put the question into the Q&A box versus the chat box. We'll be fielding the questions from the Q&A box, and Christine will be here to answer any of your questions. And if you want to put in where you're from into the chat and let everyone know how much of the country is represented, that would be great. And I would also like to say that I am here broadcasting from the unceded territory of the Algonquin and Anishinaabe people in Ottawa, Ontario. And now I'd like to introduce our keynote speaker for this evening, Dr. Christine Murphy. I had the absolute pleasure of working with Chris while she was on the NSWOCC board, from president-elect to president to past president. And I can tell you that you're in for a real treat this evening. Dr. Murphy is a registered nurse and a CNA certified NSWOCC and she studied tissue viability and professional practice at an undergraduate level and did a Master's of Science of Wound Healing degree from Western University and went on to complete a doctorate. She has expertise in assessment and treatment of lower extremity wounds in the vascular surgery population and a focus on ultrasound debridement and wound infection in her clinical practice. She has many different professional activities that she's been involved in, including the 2013 RNAO Best Practice Guideline Update on diabetic foot ulcers, and is a stakeholder of the current RNAO Best Practice Update on pressure injuries. Chris currently works at the Ottawa Hospital with a specialty in complex surgical and vascular surgery wounds, and her position incorporates the care of patients in the pre- and post-operative phase, including ostomy surgeries, surgical and trauma wounds, and limb salvage management. Additionally, Chris is an educator and mentor for health professionals and interested in complex wound management. Please join me in welcoming Christine Murphy.
Well, good evening, everybody, and thanks, Kathy, for that lovely introduction. Hey, I'm going to jump right in and share my screen here. Get that piece going first. There we go. And I'm just going to ask Kathy, that is showing okay?
Yes, it is.
Perfect. And I'd love to thank Solventum for sponsoring this session tonight, formerly known as 3M. We were just saying, like the artist formerly known as Prince, this is the company formerly known as 3M. And we will have to get used to the new name as we've got used to our own new name through NSWOCC Canada. So tonight we're going to talk about Collagen ORC and hopefully explain a little bit more about where this dressing is used and when you might reach for it, and how it interacts with the wound to support healing. So tonight we're going to share and describe some of the challenges of complex wound healing. And those of you on the call tonight, I know you're all dealing with this day to day, and you know, sometimes it's you know, 3 steps forward, 2 steps back, and we're looking for the most direct way to get these wounds to heal. We're going to talk about the mechanisms of action and how it actually works. I find that if you understand sort of how things work, then you can much more easily put it into your own practice. And then we're going to discuss the role of early proactive care, because I think for many years, people have spoken of these chronic wounds, MMPs being associated with chronic wounds, and this is sort of, after so many weeks, and we start thinking about that, and that's kind of not thinking anymore, and we'll talk about that a bit. So wound chronicity. So wound chronicity meaning that a wound has been there for a period of time. The term, I'm going to talk about the term chronic wound actually being a term that is sort of losing steam as something that people refer to. And those of you that know me know that I don't like the word chronic wound, because the minute you start saying something's chronic, it implies that it's unsolvable. If you have an unsolvable problem, you're not going to get funding for very innovative therapies for an unsolvable problem. So the wording is not something that supports you and your practice as far as growth. So we now are saying hard to heal wounds, but there's no doubt that these wounds have a chronicity. In the past, they can be very difficult to heal, and they can be stuck, right? So this is what we mean by chronicity, but hard to heal is a more intuitive term that suggests that these wounds are, with the right resources, we can tackle them. Over 50% or around 50% of home care delivery budget has been related to some form of wound care. And, this message still is something that is unknown to the public, but we know that a great amount of money is being spent on this. And when we say wound care, think of things like the antibiotics, the PIC care, and all of the associated care delivery things that need to be provided that add to this cost. So it's nursing time, and that affects nurses that are available and so on. So it's sucking up a huge amount of resources. So if we can turn these wounds into acute wounds and get them healed, this is a big relief to the system. When we think about diabetic foot ulcers, which most of us deal with in some capacity, and I certainly deal with these in a large proportion of my practice, they're now, more expensive than the 5 most expensive cancer treatments. So each of those cancer treatments individually, the cost of diabetic foot ulcers is more expensive than each of those. So, this is a huge problem. This is something that, most people can't even imagine how much it's costing. They think, oh, chemotherapy is expensive and so on, but cost of diabetic foot ulcers is more. Back in 2007, I mean, this is a long time ago now, right? But we were talking even then, $511 million a year in Ontario for low extremity wound care. So we're just talking about low extremity wounds in the community alone. We're not talking about hospital care. So this is an insane amount of money, and you can be sure it's gone up substantially. We need to get those data, sort of someone out there to count those, someone out there to do a new study on this to get our numbers up. But I mean, we know that this is a ridiculous amount of money. We can't even speak about the personal costs, in families and, people that can't work, can't support their families, and the time spent on admission, time spent, off their feet or out of commission. And, a large percentage of these hospital admissions are patients with diabetes. In fact, the majority of patients with diabetes are admitted into hospital when that is required for soft tissue infection or osteomyelitis. And this continues to be the case, and it's often emergent. So these patients are often in emergency because they've done something to their foot and they come in and then they have pain or infection, and it rapidly evolves into a very big problem. So we've all seen those patients that this has happened to. So when we think about normal wound healing, so if we just step back a bit and how wounds should heal, you think of, the 4 stages, right? So there's hemostasis, when you have the clotting and the original injury, and you get a provisional matrix immediately put down. So the idea is that the body stops the bleeding and puts in a provisional matrix to sort of rebuild and repair initially in a very emergent fashion. And then the inflammation happens, right? So you get more fluid in the inflammatory phase. And this is to allow the cells and the components that need to repair the wound, the defect, to sort of move around and coordinate as they need to do. So the inflammatory phase, the fluid is required, but it's not meant to be excessive and it's not meant to be sustained. There's a cell response, a sort of come hither sign when there is injury. So there's a cellular response to the area and you get proteases at that point. And we'll talk a bit more about proteases in just a minute. And then ongoing, you get proliferation, right? So now you get new cell, new granulation tissue growth. So you've got to fill in that defect. So the idea is that we need to fill that in with tissue. So in order to do that, you have angiogenesis, which are new, like tiny blood vessels that are required to feed the granulation tissue. You get cell division or mitosis so that you're actually got the building bricks, if you will, of that tissue that we need. And then you've got collagen deposition, of course, which is the scaffold that holds everything into place because things don't just float in the air. We need a solid structure. And then you've got remodeling that occurs as the fourth stage where you're getting the resolution and the closure and the skin's sort of growing in. So, I mean, the goal and you may not think of this when you look at wounds, but the way I like to think of this is there is a defect, and having determined what caused the defect and hopefully dealt with that, now you've got to figure out what we're trying to do here is how do we regenerate that tissue mass that's going to fill in that hole? So our goal is to regenerate a functioning group of cells. Remember, this is living tissue. It's not just building materials. And they have to be adhered properly to a stable matrix base, right? A stable scaffold, which is in communication with the vasculature. So the capillaries and so on that need to feed the tissue and remove the waste while you're closing the defect by doing this to prevent pathogen entry and the infection of the area, which is going to send everything sideways on you, of course. So in keeping with, thinking about these phases that the wound has to go through, where do things go wrong? Hemostasis is something that occurs in minutes. You've got to staunch the bleeding so that you're not going to be, unstable in just your living situation, right? Within days, inflammation happens, and it should only last a few days. This is the state where, again, the cells and so on are moving around, and it's a bit more fluid in the environment, and that should then resolve. And then, what happens is this is where you've probably heard this stuck in the inflammatory phase, and we've been taught that chronic wounds are this sort of stuck in the inflammation phase where we get, healing that's just doesn't occur, and it doesn't move on to granulation. It doesn't move on to that proliferation phase and the remodeling. So you get these wounds that last for months or even years that just don't heal. Now, I'm going to argue that these wounds are not just stuck in the inflammatory phase. And again, coming back to words, I'm very big on words. My daughter did her master's in rhetoric theory and the importance of the correct word for the correct term because it influences our understanding and our reaction. If this isn't just inflammation on pause, because if it were, what would we do about this? This is actually hyperinflammation. This is a dysregulated hyperinflammatory state. And when you understand that it's dysregulated and it's hyperinflammatory, then you can understand that you need to get it back in line, back it into a regulated, proper inflammation state to move it on. So how do you do that? And why is it hyperinflamed, right? If you want to know how to get things back on track, you've got to know where they've gone off the rails. So where do they go off the rails? They go off the rails because of this hyperinflammation, and that is influenced by bacterial contamination in part. What we've learned in the past couple of decades with many key scientists that have published big papers on this is that biofilm critically influences this phase. So when you have bacteria, you have an open wound, all wounds are contaminated. There's no such thing as a sterile wound. Not even in the operating room, there's going to be at least 1 or 2 bacteria in the wound at all times because that's the environment we live in. So all wounds are contaminated. If you get an open wound that's been there for any length of time, those bacteria will form biofilm because that's their preferred state of being. They want to protect themselves. They want to make sure that they're impervious to, any kind of onslaught of antibiotics or antiseptics. So they're going to form biofilm. The biofilm is in part the reason that this inflammation goes awry. And we'll discuss that more in just a minute. So you get this hyperinflammation. Hyperinflammation is in part a result and a cause of increased proteases. So where do the proteases come from? This is the big question, right? Why are the proteases there? Proteases are there to normalize or restore the balance of the injured tissue by taking out the necrotic tissue. So the host proteases, it's important to understand there are two different types. There are host and bacterial proteases. The host protease is there to redesign the damaged tissue, to remove the garbage, the destroyed tissue, if you will, so that new healthy construction can occur. But because bacteria are opportunistic and form biofilm, the bacteria and biofilm also secrete proteases. You've got this little war going on. And proteases, which are protein-eating enzymes, will degrade the extracellular matrix, which is the scaffold that tissue is built on. And it will degrade growth factors. And growth factors are the site supervisors, if you will, that will sort of inform different cells and products where to go to rebuild the tissue. So without growth factors, you have disorganization of the processes that are required to remodel the tissue. And so things just don't happen. As you get degradation of the extracellular matrix, you get more debris and you get more opportunity for bacteria to be there. So you're increasing the availability of proteases in the wound, and the proteases are eating the tissue as well as the damaged debris. And so you get more inflammation, you get this hyperinflammation and more fluid. And this war goes on and around. And, we think of biofilms as a parasite. The biofilm just lives on the wound. These bacteria live on the wound all nice and protected, but they're just being there is an irritation. And if you think of plaque in the mouth, on your teeth, plaque is biofilm. And if you forget your toothbrush, if you're going to conference or something like that, you forget your toothbrush, you can feel the irritation and the inflammation, the mild inflammation on your gums, and you're sort of dying to get that toothbrush. And if you leave that for a few days, if you have no access whatsoever, you know that you're going to be pretty uncomfortable in your mouth by then. Well, this is what's going on in the wound too. What's happening is the biofilm is there like a parasite, making itself quite at home, thank you very much, and secreting low-level proteases at the same time. This is part of the irritation that you feel. And the body is pushing back, also producing proteases. And this will go on. This irritation will continue in this hyperinflammatory state until you manage to clean this off and deal with the proteases. So think of those biofilms as a parasite. Think of them upregulating those proteases, and you will understand that proteases are a target for these wounds with chronicity, these hard-to-heal wounds. So biofilms are protective, resilient bacteria, as we've mentioned. Of course, because they secrete this, this covering that protects them, swabs don't access necessarily biofilm bacteria. This is one of the reasons why we say tissue culture is better than using the usual swab. If you take a swab, the swab is not going to penetrate that coating that protects them. They're hiding in there. But if you take a tissue culture, then they put that in a centrifuge and the tissue is spun, the bacteria released, and you're more likely to get biofilm bacteria. And of course, these biofilms upregulate protease activity, as we have said. So in keeping with, trying to make the language accessible and understandable so that then we know what to do about this. Recently, I had the privilege of publishing with Phil Bowler, who was one of the original publishers on biofilm back in 2000. He wrote actually a very large paper, which is a seminal paper on the topic. I invite you to look that one up. And also with Dr. Fahad Chowdhury, who is one of our infectious disease doctors. We sat and we thought about, let's correct the course on what is happening with this hyperinflammatory state. And we published this article in a Journal of Wound Care just about a year ago now. And we proposed that instead of sort of trying to describe this condition all the time, we give it a name. So much like gingivitis in the gums, this is granulitis. And the idea is this is a hyperinflammatory wound pathology, which is biofilm induced, and it's very common in wounds. And we need to target the granulitis, which is the hyperinflammatory state with proteases that are in elevated levels because of this biofilm. So we're hoping that this makes it a bit more intuitive for people to understand, I mean, if you think about an elevator speech and maybe you've got some politician or a funder in the elevator with you and they know nothing about wounds, what you can say is that, well, wounds, when they're open, bacteria grow in them. And because of that, there's a reaction, which is granulitis to the bacteria, to the biofilm. And if you don't manage this properly, then these wounds become non-healable. They just don't move forward. How do you manage that? Well, you manage that through, having wound experts on your team that know how to manage this. And it's an ongoing thing, much like, dental hygienists are hired in every dental office. We should have wound experts that are hired anywhere they're looking after wounds to manage this granulitis condition properly so that we can reduce the burden of wounds that are costing us so much in our healthcare dollars and time. So battling the biofilm, we're going to physically remove it as best we can, of course. We can't be there constantly physically removing all of the debris and so on and all of the biofilm. So you want to do regular, wound and peri-wound care to make sure that you're reducing the bacteria physically as much as you can by decontamination and prevent regrouping as much as you can of the biofilm and reduce the proteases. And you can see this is a fluoroscopy light imaging of this particular wound. And I don't know if you can see the pale, I don't think it's showing up very well in these areas, but the pale pink, this is extra bacteria. It's more than 10 to the 4th of surface bacteria. The bacteria love to live in the periphery of the wound and the edge of the wound. So it's very important to clean the wound and the peri-wound and the skin and to make sure and keep those edges nice and fresh. Dark area in the middle is, this is a wound that has been debrided, and that is blood and clot that shows up in that light. So pre and post debridement, we're seeing here that we do have, the same bacteria is there. It takes more than just the debridement to take care of this. So proteases, again, to define a protease, it is an enzyme that performs proteolysis, right? So it breaks down the protein, which is tissue, but it's also the damaged tissue and the necrotic tissue. So we need those. We need those initially on injury. Also, proteases blast the tunnels for the new capillaries. We need that too. So when you have new granulation tissue, the reconfiguration of tissue, you need at first, granulation tissue is highly vascular, and you need a large amount of capillaries that are produced and then regress in that initial healing time. So proteases are necessary to blast the tunnels that allow those new blood vessels to be in a three-dimensional tissue around the wound. There are around 25 proteases that are involved in these wounds that we see. And together they can dismantle all components of the extracellular matrix or the scaffold of the tissue that you're trying to repair. Now, the idea is that they're there for this reason. They're there to make the environment conducive to healing, but they should regress pretty quickly so that the formation of new tissue can occur. But when you get these hard to heal complex wounds, this elevated protease activity causes ongoing destruction, which is not a good thing and gets us stuck in this area where wounds just won't heal. So again, we talked a bit about growth factors being the coordinators of the wound environment and all of the cellular components that are needed to get together to sort of reform this living tissue, which it's an amazing and very complex sort of dance that has to happen. But we've known about growth factors for a very long time. 1962, Folkman described growth factors as an invisible substance that must be communicating between non-adjacent tissue components. So these tissue components were not touching each other, but they were still communicating to coordinate movement and activity so that tissue can rebuild and repair. We need them. So when we look at proteases in hard to heal wounds, these wounds that will not close, what we find is with a healing wound, you can see this in the purple there, protease activity goes up and then it goes down, and then the proliferation and the remodeling and so on happen. But in the non-healing wounds, so those wounds that just aren't getting anywhere, that you're just not getting any place with, the protease activity is elevated at more than double of what it would normally be. So it's causing this hyperinflammation, and it's sustained. It doesn't drop. And so long as it's hyper and it's sustained, you're not going to have great success in getting tissue to grow in the wound, the edges to come in and so on. And proteases, you know, in different types of wounds, I mean, we see there's a variety of proteases, but you know what? They're in venous leg ulcers, diabetic foot ulcers, pressure injuries. You'll notice some of this language is older just because this is an older document, but we've known this for a very long time. We don't need to redo research that has already proven that there are elevated proteases in these types of wounds, and elastase is also present in high numbers in these types of wounds. And there's a mixture of different proteases, but again, together they are very, very damaging. For example, MMP8 degrades native collagen, and 9 and 2 degraded gelatin. So these are all components of tissue. And the human neutrophil elastase will degrade the fibronectin and so on. Well, why do you need fibronectin? You need fibronectin to glue your components together. This is an adhesion molecule. So if you can't adhere your cells to your scaffold, you're not going to get a good solid granulation developing. H&E also degrades growth factors, so things like platelet-derived growth factors, and we see this in diabetic foot ulcers, which are known to be depleted in PDGF. You're not going to get remodeling of tissue if you don't have adequate PDGF in a diabetic foot ulcer. So, you know, these things are important. If you don't have enough growth factors that allow or coordinate the skin to form on top of the granulation tissue, when you're at that point, you're going to have issues with the ultimate closure of your wound that may have filled in but just didn't get any further than that. So thinking about MMPs and H&E together, they will degrade all soft tissue components. So it's a big problem. So how do you know that this is a problem? How do you even know that you've got elevated proteases in the wound? Well, the clues are going to be you've got a stalled wound, a wound that's just not getting anywhere. My vascular surgeons often refer to this as poor protoplasm. Like the tissue just doesn't look very good. It's not formed very well. It may be a bit translucent. It may be very friable. It may be, you know, easily torn apart. A complex wound, 4 weeks old, I'm gonna suggest that you don't wait that long. We know our problem wounds, like when they walk in the door, most of us, when you've been around for not too long, you get to recognize that pretty quickly. Anybody that's suppressed or, you know, has any other underlying reason why they're not going to form good granulation tissue, they're much more likely to have elevated proteases. So that poor quality granulation tissue, compromised host, serous drainage. Of course, remember that inflammation requires extra fluid to move the cells and components around. But this, again, sort of upregulates to a point where it can be both annoying and destructive. So what might you see? Well, you might see that an edge that just does not move across, right? So you've got this stalled, rolled, or cliff edge appearance. And this is because you're getting the impaired cell migration. Cells just don't move across. And then you've got suboptimal angiogenesis. You don't have the local blood supply because even the formation of the capillaries won't happen properly if all of the factors aren't in place to build them. So what do? Well, you need to address the microclimate. You need to address what is going on here. And of course, these complex acute wounds, you often need a team to do this. You see in this particular picture, this surgical groin wound, it's not moving forward. The tissue doesn't look good. There's some granulation tissue, but it's not very well modeled. But we can also see that there are holes there. This person has had surgery for a reason, so it's quite likely that they might have a prosthetic bypass under there. And what is the state of that? Is it infected? Is there a seroma around there? Is there, an abscess in there? Is there anything else that needs to be explored? Is there an anastomosis and so on? So you're looking at the wound itself and figuring out, well, why isn't that healing? But you're also dealing with the complex issues of the patient. How can a dressing help in some of these complex wounds? Well, different products can help by, again, rebalancing the wound environment, making the moisture balance, has been said many times over, not too wet, not too dry, like the surface of your eye. That's what you kind of want to aim for, your moisture balance. So to rebalance the wound, you don't want wounds too wet, especially when the skin sort of is growing in at the end. If you add too much moisture at that point, you are going to drown those new little skin cells. So you're actually better to be a bit drier when you get to that point. pH balance, and this is something that, if you're dealing with bacterial growth and trying to reduce the chance of infection, you actually want an acidic more wound, much like the acid mantle that we all know about. And the skin to protect against infection, a lower pH is going to reduce the likelihood that bacteria like to live in that environment. You're going to reduce the inflammatory proteases with some dressings and stimulate positive wound healing by doing things like supporting the angiogenesis. So giving a place for those new capillaries to grow, to provide components for that extracellular matrix scaffold, to provide the correct structure for cell attachment. So when those cells attach to the extracellular matrix, they actually have to fit, particularly if you think of a microscopic hook, if you will. If it's broken, the cells are not going to be able to attach there. So the collagen and the extracellular matrix has to be of the right shape and the right fit and not too tightly bundled, which that's often a problem with diabetes. We have to support mitosis, so cell division, so that we've got granulation tissue growth, and we have to protect growth factors. There's a lot of things going on as we're trying to rebuild these tissue. So ORC collagen, what does the dressing do? Well, it contains some different things. So it contains native collagen, which is, I'm going to say, intact collagen, which I'm going to say is the building components for the tissue. So what does that do? So in part, it acts as a decoy for proteases. So the proteases, rather than eating the tissue, will eat the dressing. So this is nice. It kind of mops them up for you, if you will. It gives a structure for new capillaries. So as we've taught, those new capillaries that are required for granulation tissue to grow, it provides a structure for them. It protects growth factors from being destroyed by these excess proteases, and it provides some physical structure for cell attachment. So if the collagen that the patient is producing through their fibroblasts is not the very best type of structure, this is going to help with cell attachment. It also includes denatured collagen, broken collagen. Why do you think you would need broken collagen? Well, if you were to be, chopping something up in the kitchen, making dinner, and you cut your finger, what you're going to do is you're going to put that knife right through collagen bundles in your hand. Broken collagen like that is the most strong signal. It's the strongest signal you can have to get all of the components that you need to the area to heal. It's a come hither sign to all of the players you need to repair that area. So broken collagen attracts cytokines. So this is sort of informing cells how to move. Growth factors. So it attracts growth factors because you've just put the broken collagen in there. So coordinators of cell repair. And fibroblasts. And of course, fibroblasts deposit more collagen, which is great. ORC. What is ORC? Oxidized regenerated cellulose. That will bind elastase. And if you remember the previous slide, you'll know that elastase can be harmful, but also elastase is necessary to convert pro-MMPs, so forming MMPs, if you would, into active MMPs that are capable of destruction. So if you don't have the elastase to convert these, or if you like awaken these MMPs, activate these MMPs, then you're going to have a lot less MMP destruction. ORC binds metal ions. Well, these are, again, matrix metalloproteases. So they require these metal ions to actually be made, if you will. So if you don't have the metal ions, you don't have the ingredients to make MMPs. And it binds free radicals, which we know are tissue destructive. And it's also bioabsorbable, as you know, this matrix for deep packings. And the one thing that, if you don't remember anything else from tonight's lecture, Promogram, the name tells you when to use it. It promotes granulation. That's where the name came from. If you don't have enough granulation, or if you don't have good quality granulation, Promogram or Promogram Prisma promotes granulation and kickstarts stalled wounds. That's when you need it. So the ORC, the cellulose. Cellulose is the most abundant material on the surface of the earth, and it's made from wood pulp and cotton. And this is what makes it biodegradable. It lowers the pH. And as we've mentioned, most bacteria like to live in the 6 and above range. So one of the things you can do is you can lower the pH to make the area less hospitable to bacteria. And some people have even said that a high pH actually may be used as a surrogate test for bioburden, because, it's a chicken and egg. Is it higher pH because the bacteria there, or the bacteria there because it's higher pH? So lowering the pH is a good strategy to control bacteria. It breaks down the sources of energy as nutrients for the bacteria. Studies have shown that it increases cell growth, protects growth factors again, and it inactivates protease activity such as elastase. So again, pH influence, poor tissue. We're talking biofilm is very likely to be here, and biofilm will in fact affect the pH. Those bacteria will influence the pH themselves. We want to have this environment acidic. We want these bacteria not to live in a happy environment. But this also, the pH is going to affect the cellular functioning. So cells function best at a lower pH, which is free of bacteria. So this is also going to align you for the healing process. And here, in fact, is a little chart that shows you that most bacteria are much happier at a pH of 6 and above. And we want to if you want to reduce infection, one of the first things you can do is you can reduce the environment that the bacteria like to live in. So, for example, Pseudomonas. We're all very familiar with Pseudomonas and those venous leg ulcers. And when do you see that? Well, you see that when you've got lots of drainage, right? Those weeping venous leg ulcers, that are under the compression saturated dressings that we all know. Well, Pseudomonas is water loving. So one of the best ways to deal with Pseudomonas is to dry the area up. And one of the best ways to do that, of course, is to make sure you've got adequate compression. So if you understand what environment the bacteria likes, and then you can take away that environment, you're less likely to have infection with that bacteria. So why is it 55-45 collagen ORC? Well, this is because they did Brita Cullen, as you can see on the slide. She was the original scientist that developed the dressing. She took all different kinds of combinations, and this was the one that was the most effective, reducing elastase and MMPs. Now, collagen is extremely important as a part of the scaffold in the soft tissue and dermis of the skin. And it's made of 3 proteins, like a rope. It's recognized as friendly by the cells. You're not going to get, sort of a reaction like a foreign product in there. And it just being there will enhance, again, the fibroblasts to come into the area and deposit even more new collagen fibers. Again, we've talked about cellular adhesion being critically important to develop new tissue and the migration of cells to where they need to be to function properly to cause that 3-dimensional tissue. Again, that's what we're trying to do when we heal the wound. We're trying to have that 3-dimensional tissue support so that healing occurs. And it's bioresorbable and biodegradable. And often, I have certainly used this in areas where you're putting a little bit of packing under something else, so you don't have to retrieve it. You don't have to worry about it. It's only going to help. It is a chemotactic signal for neutrophils, macrophages, and fibroblasts, meaning that it's a come hither sign. And again, acts as that sacrificial substrate for excessive MMPs. So we know that proteases will contribute to tissue damage, but they will upregulate the virulence of biofilms because, these are all living things. Our tissue is living, the biofilm is living. And if there are more proteases and more damage going on, bacteria will live there and more biofilm would be there. So not only in host proteases, but the collagen ORC with silver led to a 77% reduction in bacterial protease activity. So, this is going to be critically important if you're dealing with these biofilms. Now, randomized control trials, I'm not sure if you know how much it costs to run a randomized control trial, but it is extremely expensive. It's going to be well over $100,000 to run a randomized control trial, often way more than that. Sky's the limit. And they take at least 4 years in typical terms. Certainly mine that I did, just with my small population for ultrasound debridement, took me 4 years to do. So these things are not insignificant. So when we want these randomized control trials for, to show the effect of something, know what you're asking for. They have 12 published RCTs, including 744 patients, to demonstrate that this works in diabetic foot ulcers, venous leg ulcers, and pressure injuries. And, ORC collagen is not just for chronic wounds. Again, who those poor healers are. I certainly, can walk in the door and know if somebody's extremely elderly or if they have a lot of comorbidities or if they're immunocompromised or they're on dialysis or, uncontrolled diabetes, etc. We know who our people are that are going to have a hard time healing. We are going to use this on those patients. One of the areas that I'd love to use this on is patients with exposed hardware. So orthopedic patients that have exposed hardware or exposed prosthetics, those deep wounds. It's really hard to get an extracellular matrix and granulation tissue to grow over exposed prosthetics like that, hardware. But if you put down some collagen there, you're now giving the products to be able to allow the tissue to grow over that, and it works very, very well. Other areas would be things like over mesh, and anything like that. Any exposed area, tendon, bone, exposed bone, it's very good to put something like this over those kinds of tissues that it's difficult to get granulating otherwise. And another area is when you can't get that skin to grow in at the end, when that epithelial tissue just isn't advancing. Again, this will help allow, again, that cell adhesion and to allow the growth factors and so on to be protected to allow that to advance. So use early to promote granulation. To transition from negative pressure wound therapy is a good time. You filled in the defect and now you want that skin to grow in. Again, to support a granulation base over deep structures. And after debridement, especially in areas of rapid resloughing. So you want to balance, why is it resloughing? Why are you getting that again? You're getting that because there's either biofilm and there's excessive MMPs. This is an unbalanced wound. So this will help balance your wound. And here I want to talk about a couple of the cases. A 59-year-old male, he's had this wound for 15 months with tendon exposed in his Achilles area. He has peripheral arterial disease. He's had multiple vascular bypass and redos. And of course, he's a smoker. And of course, he hasn't quit smoking. And it's really difficult for people to quit smoking. So, I work with the vascular population. We have a lot of smokers. We still treat them. We do encourage them smoking cessation, but these patients still need help with limb salvage. So as you can see, he has a very difficult wound with the tendon exposed, and you can see the edge of that wound. It's not advancing. So again, rebalance the wound. There was a light surgical debridement done by the vascular resident, and then we started him on the Prisma dressings, and in no time that tendon closed over. And again, here we have another 64-year-old male admitted to the vascular ward with a left lateral ankle wound. Peripheral vascular disease, again, multiple revascularization procedures and hypertension. And you'll notice multiple revascularization redos and so on. When patients come and they have a revascularization, whether it's an angioplasty or a bypass, and their wound's still not healing, also please, please, please do consider that they may have reoccluded or be on the path to reocclusion. Certainly with angioplasties, we like to get these people healed up or well on the way to healing within 3 months. Because those angioplasties can dwindle in effect, and even bypasses can, not be sustained, especially if people keep smoking. So do think that they often do need multiple redos. So send them back if they're not progressing or they're getting infections that just keep recurring. But you can see here that he had this wound. These malleolar wounds tend to be very challenging to heal. And he was not really producing great granulation tissue. It was patchy. The edges, again, were challenging to get to move forward. But, we were able to get him, again, cleaned up. You have to pay attention to your wound bed prep, of course, always. And then to use Prisma to close. And got a very good result out of that. And considering he also had, you'll notice the left sartorius myoplasty. I mean, he had a groin wound that we were also dealing with that healed well. We wanted this wound to heal and he could get on with his life. He's pretty young yet. I will talk a bit about Prisma with VAC therapy, which is US approved, but it's off-label in Canada. And what I mean by that is that you have to say that it's off-label in Canada if you're presenting this. But in the US, it's been considered safe to do. This is a patient I had actually some years ago before they even had the silver foam. So that's how long ago it was. And he was a patient that he had this, you can see this first ray amputation. We were trying to save this foot. And he had a heart attack on the table when he was having his ray amputation. So went to the vascular surgery operation, and yeah, had a heart attack, arrested on the table. So he went to our sister heart institution to have his heart looked after. He had to have a bypass done pretty urgently and so on. So he was over there, and often when cardiac surgery look after patients, they don't really look at feet because that's not glamorous like the heart. And so the dressing was on, and about a week after he went over there, I didn't know this man at the time. I got a call from the nurse over there saying, "Oh, I got this guy and he's got this like dressing on his foot, and I think he's had some vascular surgery, and would you mind taking a look?" And so what I came across was the first picture, and you can see he's got bone sticking out there in the middle of the picture, and he's got some tendon necrosis going on, and he's got his granulation tissue is just like, yeah, no, it's just not working. So we put him on some regular VAC. Of course, we got ID to see him, antibiotics, all that kind of stuff. And honestly, he didn't do that well. He had very poor granulation response. And we were thinking, oh, this is looking like he may lose his foot. So I talked to the vascular surgeon who was covering him at the time, and I said, he's not granulating, and I'm wondering if I put some silver in there. So remember, we're talking a long time ago before the silver VAC dressing was available. I'm thinking I might put some silver in there and maybe give him some local antimicrobial as well. Maybe that will sort of perk things up a bit. And the vascular surgeon said to me, "Well, you want to put something under a VAC? That's nuts. You're nuts." Which, okay, fair enough, And I said, "Well, okay, do you have an objection? Because it's not going to harm anything, and he's not moving anywhere anyway." "No, I don't really object, but I think you're nuts." Fair enough. So we put on the Prisma under the VAC because I thought, well, it's going to melt, right? We fenestrated it. So we cut little slits in it so that the suction could still work, but it's going to melt. It's not going to harm anything. It's not going to be in the way. You can't put a solid dressing, obviously, under a VAC. So we came back and we saw him about a week and a half later, and he had this beautiful granulation tissue that had started. I mean, it was stunning. I just can't even tell you how great this granulation tissue was. Now, this is not just silver. I mean, we've all used silver dressings, and silver helps, with bioburden, but it doesn't give you beefy, beautiful granulation tissue right away. And so we discussed it at some length, and really to this day believe this is protease management, this is protecting growth factors, this is reducing pH, this is normalizing the environment and providing the collagen that provides the scaffold for the tissue to grow. So that we were then able to skin graft, as you can see below, and he had a very nice result and got to keep his foot, and he's a pretty young man, so he was extremely happy with that result. But that was one where initially it just wasn't working. So in summary, I'm going to say a balanced wound environment equals success in healing. You've got to think about, why is that defect there? What might be going wrong with rebuilding of the tissue? How can you rebalance the environment? Think early intervention, though. Don't wait till things have really gone sideways, and have a plan. And remember, the least expensive wound is a closed wound at the end of the day. So, this is not an expensive therapy at all. But, a basic dressing that you're putting on there and getting nowhere, and you have somebody on service forever and ever, that's not a plan, and that's not cheap. And with that, I think I will take any questions.
Okay, thank you, Chris. There are some questions that have come in, and if any of you have questions for Chris, this is the time to ask them, so please put them in the Q&A box. So the first one says, according to Promogran, and it has CLWK, so click, that this is contraindicated in use in infected wounds and not to be used until the infection is treated. So why would it be recommended in a wound with biofilm or infection? Wouldn't the biofilm infection need to be resolved first?
So biofilm is bacteria's natural state. So biofilm and infection are two different things, right? So you have plaque, everybody does, and on your teeth every day. You don't have an infected mouth. So biofilm is there. Acute infection. So infection is something when the host is overwhelmed, right? That's when you have infection. It's not just the presence of bacteria. When the bacteria overwhelm the host, has to be treated. Yes, absolutely. So if you have an acute infection, those people need to be on antibiotics, but you know, the Prisma and the Promogran will not resolve an acute infection. That's not their role. Antibiotics do that. But yeah, as soon as you start treating them, we don't slow down the starting of it. We make sure that they're treated. But when somebody's in treatment, and it's the same with VAC therapy, once somebody's treated and they don't have a raging acute infection, then we go ahead.
Okay. The next question is, will this dressing work in a wound that has necrotic tissue present?
So it's not going to be a magic wand where it's going to make necrotic tissue granulate. You need to remove the necrotic tissue. Now, if you have a little bit of necrosis, so it depends, right? Most of these answers are going to be, it depends on the patient in front of you. If you have a little bit of edge necrosis or a little island or something, and most of the area is looking, you know, like it might granulate, like there's a potential. It doesn't even have to be granulation tissue. It could be you've got exposed tendon or something. If you've got a small area and you are not able to remove that necrosis yourself, you don't have access to someone, I wouldn't not treat with this. But obviously, if it's mostly necrotic tissue, mostly slough, you've got to deal with that first because it can't interface with the tissue and it can't support that tissue environment.
Okay, and I think the next question actually feeds into that as well. Like, do you need to have no slough to use Promogran, or can you apply it when slough is present?
Again, you know, if it's thick slough, that's not going to work. If you've got a little minor slough, I would say you need to clean the wound a little bit better as much as you can. So again, if you have some area that it's going to work on, that's great, but you really want to do your wound bed prep. And if you don't have access to people that can debride, or you can't do it yourself, then you need to figure out a pathway that you can get access for your patients, because not being able to debride and provide wound bed prep is a big issue. You know, your patients won't progress.
Okay. When applying Prisma under the VAC, do you apply it directly under the black foam or with an interface such as Adaptec? Will the black foam strip off the new granulation tissue when the black foam is removed?
Ah, very good question. So again, this is off-label. I'm going to say that, but when I do that, the Prisma is fenestrated, so there are little slits cut in it, and it's directly under the black foam. I try not to use interfaces unless absolutely necessary. So absolutely necessary meaning there is a structure of concern. You know, yeah, you can follow the guidelines about that. And when you're using the interface, just cover the thing that you're trying to protect. And also, you know, think about whether or not a white foam might be an option too. But the way that negative pressure works is by pulling that tissue into the little holes in the foam, the interface of the tissue and the foam. So when you put the collagen dressing in there and it's melting, you're pulling that collagen in, but you're still deforming into the structure of the tissue and the foam. When that tissue is pulled into the foam, you get mitosis, you get cell division, which is granulation tissue growth. If you put an interface, I tell patients it's kind of like, you know, putting a sock over your vacuum hose and then expecting it to work properly. It just doesn't work the same. It's really going to slow things down. So when necessary, and if it's absolutely necessary, then you would put the Prisma down first, and then you'd put the interface, and then you put your black foam. But usually, for example, the patient that you saw there, that we used it on a long time ago, we put the Prisma down and the black foam, and we're not worried about pulling the tissue. And in fact, if you get some bleeding on removal of the foam, that's actually a good thing, you know, so long as it's not like hemorrhage, if you get bleeding on removal of the foam, you're getting release of growth factors. You're taking it back to that initial stage of healing. You're resetting it to an acute wound. So a little bit of bleeding is good. You just have to tell patients that actually we're kind of making this into acute wound if there's a little bit of bleeding, but we don't want too much pain.
Okay. Can you use Prontazan along with Promogran?
So the two companies are separate. I don't see any reason why not. To use some of these anti-biofilm solutions to reset the wound, to reduce the biofilm and so on, that's a good idea because it's part of wound bed prep. I would just make sure there aren't puddles of a solution sort of remaining when you're putting it on because, the interaction has not been studied. But I can't see that you're going to cause a problem so long as you don't have like puddles of solution there. In fact, it may help.
Yeah. Can you use it for packing a deep wound?
Yes, you can use it for packing a deep wound. The benefit of it is that you don't have to retrieve it. And one of my major bugs is people being told that they must measure depth and they must explore the entire wound that way because oftentimes they keep wounds open by measuring depth and they can introduce external bacteria more deeply the more they probe. And so the probing and so on should be kept to an absolute minimum. And if you're going to put this in a deeper wound, you're not going to put it in with any force, it just very gently. And it often can feel those little nooks and crannies around under a vac that you may have difficulty with. Obviously, you need to have a plan and know, the diagnosis of your patient and what body parts are where and that you don't have like organ exposure and that kind of thing. But yes, I would say in general practice, yes.
Yeah. And can you layer it? And what is the recommended time frame to reapply? And when you're cleansing, do you have to remove it completely? So can you layer it?
You can layer it. Yes. Do you remove it? No, because we're donating the collagen, right? We want to use this as building material. So you don't want to remove it. It's the same with any extracellular matrix or bioabsorbable collagen dressing. You don't remove it and you replace it when it's gone. So you time your dressing changes based on how quickly it's used up.
Yeah. And will it work on hypergranulated tissue?
So you got to think again, why is tissue hypergranulated, right? Again, it comes back to why are you seeing what you're seeing? So hypergranulated tissue is a condition that is always one of excess moisture and bioburden. When I say bioburden, it could be biofilm, likely it is. It doesn't necessarily mean infection, but there's too many bacteria. So you certainly need to have a dressing that's going to absorb better than you have. Or maybe you need compression, or maybe you need somebody's heart failure to be fixed so they're not pouring fluid, whatever it is, but you've got to turn off the tap and you've got to apply an antimicrobial. So in doing those things, the hypergranulation should settle down. But then again, it's poor quality granulation. So yes, this can actually help, but you have to address the condition first.
And can you apply it to a diabetic foot ulcer with an ABPI 0.6 to 0.9?
You can apply it to diabetic foot ulcers. I do it all day long in my practice. I usually post-surgical diabetic feet. It matters not what the ABI is. You need to have adequate perfusion to heal. But as far as the dressing itself goes, that's not a thing. We don't have a cutoff. If their ABI is 0.59, but they're progressing. So if somebody's ABI is low, they would go and see the vascular surgeon to see if it can be optimized. But that's not a reason not to use a dressing. In fact, in vascular surgery, you have people who we can't revascularize because they're too either old or too sick. And this is actually a dressing we go to as a, well, we can at least try this because it's going to support tissue growth if they're able to do it. Because some people who are sort of borderline, they can actually manage with a really good wound care to granulate and heal.
Yeah. And do you have a preferred cover dressing that you like to use?
I don't have a preferred cover dressing. No, it depends on the moisture balance that you're looking for. On lower extremity wounds, we do not use occlusive plastic type dressings, just because that will hold in the moisture too much. In fact, I think they're not even indicated for lower extremity wounds. You need something that's got a little bit of breathing room, if you will. So, you know, a foam dressing that has some kind of ability to allow that moisture to go out. So most of the new foam dressings, they're fine. But again, if it's highly plasticized, not a good idea. Or even a paper type dressing, depending on the type of wound that you're looking after.
Okay, and we just have time for one more question. And for the questions that didn't get answered, please email office@nswoc.ca and we will get your questions to Chris and make sure they're answered. You mentioned biofilm likes living in the edges of a wound. Is it best to cut the promogran to size or overlap the edges of the wound?
It's best to clean the edges of the wound and clean off any scales and so on. It actually doesn't matter if it's touching the edge of the wound, except for, you know, maybe the silver may help a little bit, but you're going to be cleaning your wound really well. It improves the wound environment, and to fill the whole wound, so the dimensions of the wound, that's going to help, but you don't need to overlap it over the edge. You need to give good care so that that skin can move across, because anything that's on skin is not going to be absorbed.
Okay. Well, I would like to thank you, Chris, for an excellent presentation. I just love the way that you made the chemistry and the cellular level of the wounds come alive. And this looks like a very interesting technology that provides another option for clinical practice. So thank you so much. And I'd also like to thank Solventum, formerly known as 3M, for the support of this webinar. You will all be getting a follow-up email that will have an evaluation form and will have a copy of the recording. And the recording will also be posted in the archive area of the webinar section of nswoc.ca. So thank you again, and look forward to seeing all of you at our next webinar.
Thanks, everyone.